So this morning, I think we had a very rich canvas of talks. It's still like drinking out of a fire hose, the amount of stuff. It will take time to digest, but it really gives a sense of how much is going on and the breadth. So this afternoon, we want to now switch to the ground reality, because unless we bridge that gap, really the applicability is not going to be there, and the reality of the frontline problems are not going to be known. And in order to do that, we've actually divided into a number of sessions, and the first of which is really to have a conversation. And we are very fortunate to have two people who represent the big bridge that we need to come across in this space. We have Lily, and Lily Peng is actually a physician, PhD engineer, who's a project manager at Google and actually drives a lot of these solutions of medical imaging as it's applied to frontline clinical care. As she said, AI is a catalyst, not a substrate, and her whole focus is how do I get it out? But as a technology company, how does it really apply to the ground reality? And that's we're very fortunate to have Judy with us. Judy Gichoya is from Kenya, is a radiologist now in Oregon, and comes with an informatics background. And she has actually implemented frontline solutions using an open source platform. So for her, non-open source that's closed is also different. And she has done and seen the frontline challenges of implementing this. And we are going to have this as a discourse that Stephanie, a colleague, is going to try and facilitate and really extract out the main themes that developers need to think of when dealing with frontline problems. And I hope this is going to be a rich discussion. Thank you.
Thank you so much, Mehul, for these great introductions and, of course, for your leadership and enthusiasm, both in preparing this and in your work in general. We're lucky to have you at HGHI. Before I get started, I also wanted to give a shout out to Megan Diamond, who's really the mastermind behind today's events. I'm sure you've noticed what a great group she has curated and how she's pacing the day. So thank you, Megan. Welcome to our keynote conversation. Welcome back, everybody, on the live stream. This morning, we exposed you to this little mini version of what a Harvard education is like, right? We've heard the word firehouse a lot. It's a tour de force, and when we do this, we not only stretch our information absorption muscles, we also are able to look at an issue with a lot more complexity, and that's what we're trying to do with this day. So I also wanted to thank all our speakers from this morning for squishing work, that you've put years and years into these little 5-minute presentations. As a communicator, I'm a journalist, right, and a science and health writer who's worked on many continents on these issues. I know how hard it is. But we're all grateful that you're doing it, because when we work across disciplines and fields, it is so important that we get these windows into each other's work. So this lunch conversation will truly be a conversation. For the rest of the day, we'll be asking these difficult questions and getting to the nitty-gritty. As we sort of keep equity, scalability, local needs, business models, all the themes that have been in the room in mind. And who could be a better pairing to get us started on the rest of the day? I'm super excited to be here with Judy and Lily, not just because this is the opposite of a manual, right? An all-woman cast at a tech event, just fantastic. But more importantly, because you two bring such great complementary perspectives, as Mehul has also laid out. You're both doctors. You both ventured into tech. You both do this interesting on-the-ground work. And as I learned in our conversations earlier, you're both also navigating and bridging gaps, right? Lily, you are a doctor who works in a technology company. Judy, you are, you're also a doctor, right? But you're bridging the US healthcare system now that you're here with the healthcare system that you've worked in Kenya. So Judy, and I'll be moderating the first half of the conversation, and then we'll get to your questions. So, be prepared for that. Judy, you're a radiologist, which is arguably the specialty, the medical specialty that feels most threatened by AI, right? You're also a technologist who sees those opportunities. Tell us a bit about a project that you're working on right now that you're excited about and why.
Okay, so just a little bit of background. I actually went to medical school in Kenya and then moved to the US for residency. And I was very lucky to go to a school in Western Kenya called Moi University. And one physician there who had retired from Indiana University lived there. And he really emphasized, his son is also a doctor and a genius, a computer genius. And in my clinical years, we were struggling to take care of HIV patients because there were many. We were using Excel spreadsheets. And then, MS Excel had a maximum number of rows that you could, write up to. And so, when I was moving to my clinical years, I was just sort of right place, right time, got involved into this open source medical record system. But the one thing that he kept saying was, you always have to lead with care, and that's, really something that I've sort of embraced. And, coming here now as a radiologist, I'm actually 4 months away from completing an interventional radiology fellowship, which is going to be tough to replace. But, it's this concept of leading with care that I want, I've always enjoyed to work on the front line to specifically make, I think of myself as the last mile doctor when I go for global health, and just to give, the technology as another toolbox that people like me would enjoy to use. So for the US, I specifically right now, I'm working on sort of like demystifying, democratizing AI by just coordinating the residents and the fellows here, giving them education and just giving a platform where engineers and other people from industry can come and interface. In Kenya, I help out with a project which is actually a mobile TB track. And the way I came to this project was we did a postmortems on our HIV patients who had early mortality in 3 months and found out that tuberculosis was the biggest killer. And so we intensified the screening for tuberculosis. And chest x-rays are one way. And so we have a mobile x-ray track that honestly we've always had a machine learning algorithm by the NLM running on, but not purely for production. It's just for continuous training. And we still rely on radiologists to read the x-rays and start anti-tuberculosis treatment.
Thank you so much, Judy. Sorry. Lily, today is a special day for you, or yesterday was, as there was a big announcement of the diabetic retinopathy project that you've been working on for years, which now got official approval. Tell us a little bit more about the project and what you've learned in the process of designing and implementing it.
Well, okay. Well, I would say probably thank you for the congratulations. I mean, it was truly, really a big team effort, and I think of kind of the announcements as like the pictures from a wedding day, kind of like you want to keep it to remember it, but there was a lot of hard work getting there, and there'll be a lot of harder work coming up ahead. So thank you. The wedding pictures are gorgeous. But yes, so we're really excited about some of the work that we're doing. I think when we first started, when the JAMA paper first kind of landed in, I think, late 2016. I think our team was still trying to figure out where this was going. We had started working with hospitals in India. That's kind of the origin of all of this. And to be quite honest, the hospitals that we worked with, Aravind and Shankara Nethralaya, I still can't say that, but the hospitals that we'd worked with in India had already had a very long tradition of screening for eye disease and had started with looking at diabetic eye disease long before we started talking to them. And in fact had been working with other institutions, academic institutions, in developing algorithms specifically around DR. So we didn't actually happen on a new application, really. We didn't invent anything. It was just the clinical community found a need and said, well, here's a need, and it actually worked with other people to try to solve this problem. Now, one of the things that was different about when they were approaching Google was this belief that we build products. We weren't just doing the research that we would actually be interested in helping implement the solution once the solution was validated. And so when we first got the paper, I think that was step one. But then since then, having had the validation in the clinics, as well as now launching into a more of something that actually scales, I think this is where the really, really hard work actually starts.
Excellent. So let's talk a little bit about what are some of the steps? What do you see coming as next?
Yeah, so I think we spent, before this CE work, we spent a lot of time looking at validation, right? So validating, and so we developed an algorithm that was trained on not only images from India, but also a screening program in the US that covered kind of a lot of the US. A very heavy Hispanic population in terms of the images, also Caucasian, Asian population. So it was a very diverse training set. And so we also, that helped, but we also wanted to make sure that prospectively speaking, as the new patients came in one of these places, that we were also performing at a level that we thought the algorithm was performing, so generalization to this population. And so we actually spent a period of time just doing this validation where all the images were actually being overread, and we were measuring how well the images were doing, or how well the algorithm was doing in comparison to the ground truth. And then after that, we actually started exposing some of the predictions to the graders as an assistance of sorts. And then now now that it's gotten approval, we're very slowly scaling the pilot from one site to multiple sites and looking at how that changes the workflow. Because I actually think that, as I said, AI is really a catalyst, and the substrate is really all that matters. And so we're thinking about how this might change the flow of patients into referral clinics, for example. If you can, take on more patients, what does that look like? If you can actually have the patients go to see the specialist in the same day, how does that change the flow of patients to the clinic? That, honestly, that will have way more impact than the accuracy of an algorithm. I mean, obviously, if the algorithm is really terrible, sure. But a few percentage points here and there. What we're actually looking for is trying to help that patient not make the next additional trip. The patient who actually needs care to actually go get care perhaps the same day, to actually maybe see a counselor to actually help their diabetes before it gets, before it actually affects the eye disease. Because let's be honest, the best way to prevent diabetic retinopathy is to treat the diabetes, right? So there are all these things about the healthcare system that I think AI can catalyze little parts of changes, but the changes themselves actually have to happen before any impact. You're actually going to see any impact in terms of patient outcomes.
Yeah, and I don't know if it's conflict, right? But the conflict between health systems and a vertical integration or something that just tries to fix one problem, of course, has been a big topic in global health for a long time, and Rifat gave us a great talk this morning. Judy, how do you think about some of the health systems, opportunities, both, the redesign of health systems, opportunities, and the challenges maybe with implementing this?
So I see the big sort of AI topic. To be honest, I see this as something that sometimes you cannot be afraid of something that you don't know. And every time I've spent time in Kenya, I've been very lucky to spend a minimum of 1 month every year. Sometimes 6 weeks actually, also in Malawi. But when I walk around and I'm working with my former classmates and my colleagues, they're not thinking like, oh, there's AI coming, It's very different from, my colleagues here who will be tweeting and writing emails. Am I going to be replaced? Is this the right specialty? It's a very big different shift. But, I also realized, though, that the way, the news will come, and we live in a place where we are reading what's trending on Twitter, and people who sort of invest in healthcare systems, at least in Kenya, is the government mainly, and then the second player is people who can afford to buy this equipment. And so I I sort of ran these scenarios in my mind. If I can buy something, a flight to China or wherever, and the vendor says, AI in this ultrasound machine can diagnose everything. I mean, we don't have the legal infrastructure to start to, if I bring back that machine in the village and say, this AI will diagnose all your diseases, there's no legal infrastructure to make sure that, does this thing work really? It's just going to, just be like in the wild, AI in the wild. That's how I kind of think about some of the bigger question. And then there's another sort of hard question that, the opportunity is big, but the pie is fixed. I mean, we only have so many resources. And so if you come and you convince a minister for health that, we will save you money. You don't need to train doctors because, I mean, we always say we are using AI for places without doctors, but the solution for that is to train more doctors, and if you go to these places and say, if we bring this AI for you, you won't need to train doctors, most likely they will believe. And they will invest this money in your AI project. What's the opportunity cost? And I want to challenge everyone to think, when you look at a patient outcome for your product, would it have been achieved without the technology? And it's a really tough question for someone who actually loves technology as me to ask myself, do I need to implement this technology? And sometimes the bigger thing is to say no and walk away.
Interesting. So, Judy, how do you reconcile? We talked a bit about bridging earlier, right? And how do you reconcile for yourself some of the challenges? We talked last night. You told me about, you get contacted now by companies who want you to recommend your friends over in Kenya to annotate, right, images, services which would be much more expensive here in the United States. You sort of sit right in between something that we all struggle with in global health, which is, right, the continued disparities and the systems that are trying to work together.
So, I mean, I'm not one to speak because I'm part of Brain Drain, but, I think, a few weeks, actually last week, 2 colleagues reached out to me and wanted radiologists to, annotate some. It's simple, actually. It's annotate the aorta and, some anatomical organs, because the reality is it's expensive to pay the American radiologists to do this. And, my automatic thing was like, oh, sure, I have many friends. And I actually did introduce them. And, at the end of the day, I was like, oh, man. I get it. They make a little more money, by doing these annotations. But it still takes, in my village, a week to get a CT read, But so now they can do it from their homes. They don't have to go to work. What does that mean for the, the bigger healthcare system? I'm not saying that I have the right answer, and I wouldn't say that. I'm not going to start, say it here and say I didn't make the introduction. I did. But that was something that came up in my mind, and I was wondering, I mean, I don't know what will be the thing. There's always an opportunity cost, and we just, there's no, free lunch in global health, even if some things are offered for free, and I think we just have to be cognizant of this cost.
Thank you. So one of the themes that has come earlier is how do we engage local communities? How do we engage people on the ground? Lily, talk a little bit about how this process worked for you.
Oh, yes. So I'm going to caveat a lot of what I'm saying by just saying that I'm not an expert in global health, so this is kind of our way of partnering with people who are. And so one of the things that I think we've learned as we're working with healthcare systems and healthcare providers in different countries and settings is that the first thing that actually we need to do isn't to prove to other people that we are smart or prove to the other people that we are right, but really actually prove to our partners that we can be trusted, right? So I think one of the things that, working with the hospitals in India, what we actually ended up doing is actually kind of proving to them that we were going to stick around for the long run. I think that there were obviously lots of other projects that were going on. And it's not because there wasn't enthusiasm, but there wasn't, I think over time, this kind of thought that we're going to move beyond a paper, right? So I think kind of working with them to show them that, hey, you know, we actually care about the things that you care about, not just where the AI sits and all that. We actually care that the cameras are usable. We actually care that this is going to be put into a place where, you know, we're being thoughtful about where we're placing potentially these cameras, right? We're listening to, so one of the really interesting things about Aravind, they actually have, especially with people with diabetes, they have this, they've been talking about how do you reach what they call non-customers, right? So in contrast with cataracts, which is, you know, people can't see and they understand, they come to you because they have a cataract, they have a problem, and the patient knows it, so they're now customers. So that's much easier than if you have diabetes and you have this silent, you're losing sight silently, but you don't know, you're not a customer. So how do we engage those folks? Because those are the people who need it. And in order to make that happen, you actually need someone in that community that people trust. To say, hey, you know, this really is going to make you lose sight if you're not careful about, you know, what you're eating. And I think most people are like, I like what I'm eating. I don't. My sight feels fine. And you know, if I'm gonna lose vision, I'm gonna lose vision anyway. You know, it's diabetes. Everyone loses vision, right? So I think that there actually requires somebody in that community that has those relationships to say, hey, no, you know, this is how diabetes works. This is why screening is important. And you can't do that just de novo as someone from tech. Like I couldn't go do that. You know, I do not have the capabilities or the relationships to do that. I can help other people, you know, our team can help other people that's doing that and help accelerate that work, but they have to trust us enough to let us help, right? So I think that's one of the things that, you know, we've learned that this is very much a partnership, and we're learning a lot about the healthcare system that I think we wouldn't have learned otherwise.
Julie, what's your take on that?
You know, I think as we go to AI, we have to remember the lessons that we've learned from just mobile health and global health. I mean, the first systems I implemented were nothing about the teaching about, you know, the UI of the systems I was building. It was about how to use a computer. We know the issues about mobile ownership, right? The heads where mobile phones are shared, the head of the household, you know, is in charge of the mobile phone. So if you're delivering care and say for vulnerable populations around something like domestic violence, that can be a difficult thing to do in such a case. You know, we have learned that there are things, there are sort of pillars. It's always bad work for people to get to do this, but it's necessary. So one of the earliest things was around terminologies. And so I would expect seeing the huge interest in sort of retinal screening for diabetes that would come up with a, you know, common nomenclature that's used in all these AI products. You know, who's going to be doing that work? Because it's not going to be the companies. You'll be focused more on your work, more than reaching out to Microsoft and anyone else who's doing the same project and coming up with a common lexicon. And those, for informatics, it has nothing to do with AI. They tend to be like really daunting work. It's not exciting work. It's not work that people clap for you when you present at a conference, you know. But someone needs to do those types of jobs for us to be able to reap the benefits of AI. Yeah.
Agreed completely. Yeah. I think it's funny because like our team, we sit at this intersection of kind of AI, you know, the really fancy AI, and then also like labeling and getting ground truth. And so we're like, everyone's like, oh, you're the AI team. Like, no, actually, we're kind of the data normalization and getting ground truth team. And they're like, no, that doesn't sound exciting. Can you guys just be the AI team? Okay, yeah. But I mean, the truth is, I think, you know, there was a reason why we started with diabetic retinopathy. It was because there was relatively good agreement around what severity levels and then where the referral pathways are at the various severity levels. You know, kind of clinical science as a whole has some round of agreement. There's a reason why we didn't start with glaucoma. No one can agree on anything about glaucoma. You look at one glaucoma specialist and they are looking at the problem completely different than another one, and they're treating at another endpoint, and then the other one's treating, you know, only if there's visual field defects, and this one's saying, well, there's going to be a visual field defect based upon what we see, right? So that we don't even have sort of guidelines around that. So without that kind of, again, substrate that has been agreed upon by the community having that done, the other parts can't happen. And even with DR, and I mean, even AMD and other kind of eye diseases where there's a relatively good agreement, you realize there's so many edge cases that you now have to, kind of expose to the KOL, the key opinion leader, and one key opinion leader just can't agree with the other one. And so we spend all this time getting people to agree. We're like marriage counseling for doctors, So I think that's actually much harder. The model training itself, I kind of, I'm a little sheepish about it. It's relatively simple once you get once you get the humans to agree. The model training is more straightforward.
Thank you, Lily. So I'll be asking one more question. Then it's your turn. Please let our mic runners know if you'd like to ask a question. As we've learned from, the tour de force this morning, this is incredibly complex. It's really hard to think about where to tackle some of these problems first and what to think about. But I'll still ask you, for each of you, what are your sort of 3 top challenges that we should be thinking about and tackling first? Between the data, cleaning up the data and governance and international collaboration and anything in between.
Yeah, well, I mean, obviously, since I just talked about this, I think agreement and standardization is sort of top of mind. And I think some of that, you can't just think about the clinical science itself and the disease progression, but also kind of what are the economics behind that, so that you can actually get screening guidelines that don't bankrupt. Like if you had followed those screening guidelines faithfully, you can't bankrupt an entire system, right? And so that's actually keeping that in mind, that like if there is a guideline, it then not only impacts clinically how we manage patients, but also how a government or a payer or whatever can afford to adhere to those guidelines. So I think that's one of the challenges of many. Okay, I'm going to toss it to you.
Okay, so I think advocacy has to be the biggest thing. And I never understood what advocacy in medicine was till I came to the US to be a radiologist. And I've gone to the Hill, and I now know what that means. And I think, if I take the American example, most EMRs are sold on the golf course, away from the doctors. You just figure out who makes the decisions and who signs the check, and you meet them on the golf course, and they'll implement your system, And the doctors hate it, and it doesn't matter. And so I think a lot of existing EMR infrastructures right now in global health are around donor reporting. And so if I tried to do decision support earlier on for clinical outcomes, but everyone wanted to know, can we report on time? And, are we showing the consistent measures? And so I think advocacy is going to be, and I really don't know how that's going to evolve, but that's going to be a very interesting spot for AI in global health. The second one, I think, is around this thing about fairness and, equity and transparency. And it's going to come on multiple levels because I think last week, if you're following, maybe 2 weeks ago, the World Food Program, licensed Palanta, which is a company that's in the US and does a lot of algorithms for immigration to manage their supply chain for food distribution. And we know, the World Food Program gives food to vulnerable populations. And so for you to license, a private company without a form of transparency, I think is a challenge, because even if you're trying to reduce, and this is something I accepted earlier on, sometimes even if you're trying to reduce fraud, if you're going to deny someone who really needs the food because you're trying to reduce one person stealing the food from you, I think is an unintended consequence, to be honest. And then I see a big sort of role for, learning from the past. I think global health, just as it has made a lot of mistakes and a lot of opportunities have arisen. And those lessons cannot be ignored sort of moving forward. And I remember when earlier on, a lot of people were starting telemedicine platforms based on Facebook. And you can imagine today, if you are sort of trying to recruit people to get vaccinations, I mean, we know that there's a lot of disinformation, which would be a big challenge and a big disservice. And so I think, it's such an exciting time, to be honest, to be doing, AI or any form of technology for global health. But as someone who's always sort of, lead with care, the answer is always so easy. If you look at the patient and say, if I did not use this technology, would I have saved their lives? I mean, it's such an easy answer. Maybe it's because I'm a clinician who's worked in these areas. It's just easy, and it's such an exciting time to enjoy the future.
Thank you, Judy. Okay, questions from all of you? We have Rifat and yeah.
Hi, thank you very much for this discussion. I have a question for Judy. So Kenya has been kind of labeled, for those of us who live in sub-Saharan Africa, as the model to follow because of the impact of mobile technology. And so it's kind of leading the way for a lot of African countries. But what I hear from you is that we're not ready yet. So the AI is more of the hype than the reality. So where would you pitch a country like Kenya or maybe Botswana or part of South Africa? Can we aspire to say that we're going to machine learning in healthcare, or should we focus one step even lower and talk about big data or the quality of data? And is there a way that we can kind of have free ride the mobile health or the mobile technology system that exists and use that in some way to have the same impact that it has on society?
So I have sort of two different, actually opposing answers to your question. And one is, I think AI is going to happen. I mean, that's just the reality. When you go to Google I/O and see what's coming, and you're like, when people say the next billion users, they're going to be in sub-Saharan Africa, they're going to be in emerging markets. So AI is going to happen, whether we're on board or off board, and that's always my message to my colleagues in the US. But I think the opportunity is to shape so that we can have the maximum benefit. So, for example, one of the earlier things when we started to build systems was we relied a lot on Java programming, to build EMRs. And I'm telling you, it was so hard to find Java developers. It's easier to train someone to do HTML. You can do this in a week, And so what I saw evolve was that entrepreneurs would come back and, sort of say, okay, we need these skills. We're going to train this, or we're going to come up with newer ways of doing this. And that was almost collapsed some of the national implementations of EMR, open source EMRs, because there was just no local capacity to sort of take care of that. And so I see also like mobile money, M-Pesa, which has been super successful in Kenya. I mean, we do everything. I can send my mom in the village money from here easily, and she's able to do her things. And if you look at sort of the success of M-Pesa, it's because it evolved to meet a need. And so instead of thinking AI, it's better to think, what problem are we going to solve? And if you look at some of the big companies, I think like Amazon, they don't think about, what is AI going to do? They say, how can we reduce the rates of shoes return for us? They look at that problem, and then they look at what solutions they have that can affect this sort of problem. And I think for us, as sort of like a continent, we have to build capacity. We have to have AI local experts who are Kenyan, who are South Africans, who have that context, I think, a lot. And we have to sort of ask these grand questions and also put ourselves in an advocacy forum where the leaders who make these decisions are hearing our voice. And that's easier. And then start to do that hard work of building those pillars that's going to allow when Lily comes and says, I want to do this in Kenya, that she doesn't have to restart to define the terminology or the equipment that's there, because we've already thought about those sort of substrate pieces. The other side of things is, as an interventionalist, I think we still suffer for many things. For example, if I had money, I'd rather make safe surgery, honestly, before investing to AI. That's what I would do, but I don't have the money, and I don't have the decision making, so.
Rifat?
Yeah, thank you for a really great conversation. So maybe just following on from your comment, I want to bring up the issue of equity and what I call the sort of the applicability challenge that I've come across in relation to this work. And the first relates to what you call the missing customers. So for TB, for example, almost 50% of the people with TB are not diagnosed. And the predictive models develop based on those who are diagnosed and who are treated are necessarily going to be quite different to those that might have far greater need because they're not present to the health system. And secondly, I heard a lot about data. If data is driving the solutions, do we have big equity issues, or should we be focusing on the problems first, then focus on the data solutions that might help address those problems? Because if data is driving the solutions, we're going to focus on conditions where data are available, as opposed to the big problems where data might not be readily available.
Yeah, I agree with that. I think it's going to be active learning where we move forward, we decide what the problem is, what we need to solve it, and we start collecting data moving forward.
Peter?
Hi.
Agree.
Oh, sorry, Lily.
That's all right. I agree. I think a lot of the big problems that we don't have stored retrospective data. And in fact, a lot of the retrospective data is biased, and it's not exactly what we want. And that's why we had to do a lot of prospective validation before we felt comfortable, putting this in a live clinical setting. So yeah, I think one of the interesting things is that we'll find. I think AI is really interesting. At least for me, it feels like kind of like a mirror. And it amplifies kind of all the warts that we have in the system. And in some ways I'm grateful because you can go find those warts and sort those out, right? It's because it's an automated system, so you just, magnify whatever mistakes or problems you have in the system. And so in some ways it kind of can help with that. But I agree that, some of the things that you want to do is actually prospectively. Now that you know data can be useful, let's figure out what are the big problems that you want to actually tackle and get the right types of data and the right types of infrastructure to collect that data overall. I think, previously we've thought of data as a way of billing, of a way of covering your, tush when something bad goes wrong, right? We don't think of data as actually useful. That you can actually use in the future as much, right, for record keeping. So now we know that data could be useful. We should think about how we need to gather that kind of in a perspective way.
So we have Peter and then Eva.
Lily, I had a question. So I love your project, and what I'm wondering about is what do you think the learning curve is going to be like if one were to replicate that for other diseases and maybe other imaging modalities or maybe other kinds of data? Or how are we going to get better at doing this so that it's not as much of an investment and struggle?
Yeah, that's a good question. So there's probably a lot of literature now that shows what we did, with the JAMA work is now lots and lots of people can do it and do it at a high fidelity. So the question for me isn't really one of, if given this data set, can you build a model that can predict other things in this exact same data set, labeled the exact same way as a ground truth? I think we've shown that is possible, and you could do that for many, many different applications. Sure, there are some that are 3D, volumes, and some that are bigger, and yes, that is technically more challenging, and you have to put more muscle behind that, but the concept kind of holds that. I think we'll figure that out. But what has been more of an issue is going back is, when I see an AUC of 1.0, I generally think the data set wasn't big enough. The ground truth wasn't, what was really the ground truth, what was in the validation? I don't think impact to human health is really going to come from eking out those little percentages in performance in a kind of controlled setting. It's going to be implementing this and then seeing how this works when you do not have optimal conditions and you can't define exactly what problem you're trying to solve. And people are going to use this algorithm for things that you had no idea that they're going to try to use for. You know, people start putting a picture of the front of the eye instead of the back of the eye, and you don't have a way of saying, well, whoa, that's not an image, that's not a retina image. I think you're going to kind of have a little bit of issues there. So I think, to your question, like how easy is it to train a model once you have the data? I think there are so many good tools out there that will help with this. I think we're trying to figure out what are the tools that will help with the prerequisite of that, which is the normalization of data and the common lexicon and all those things.
Yeah, I would just like to push you guys a little bit further about Rifat's question. And I mean, obviously, I have a prejudice about this because I made that clear before. But, this is back to the old saw about, if you have a hammer, everything looks like a nail. And because you can come up with an algorithm doesn't mean that you should come up with an algorithm because it's not fit to purpose. But because you can make an algorithm doesn't mean that you should even be in that area. I mean, if you have global problems about, safe surgery or safe roads, and people have huge neurologic trauma because the roads are bad, then, the money should get spent on fixing the roads, and then you have less car accidents, then you have less head trauma, then you've just, done, it's a huge act in terms of global health, as opposed to an AI that isn't actually suited to the purpose for the place where you are. So I would just like to elicit a little bit more discussion about, as a discipline, thinking with discipline about where we apply these tools and where we sort of seed the ground and say it's not something that needs to be improved. It is a health state that doesn't even yet exist. One could argue the same for, child mortality in the United States right now, and maternal mortality, actually. So it doesn't feel right to me to just keep saying, well, we can do this with AI. I mean, the question is also, should we be trying to create an AI solution here? I'm with you. I mean, I would do surgery, right? Safe surgery. I mean, is there, and I think that was your question, isn't there more of a dialogue for this group to have about that question?
If I, and it's a little, for me, and this is one of the reasons why I decided to not completely leave medicine and just always sit at the intersection, was, I mean, it really grounds you, and to also see some of the, so I'm doing interventional radiology. There are only 5 interventional radiologists in Kenya. I probably will be the 6th. They're all trained outside. And the last time I went, it broke my heart because I didn't realize that in Kenya, where we're still thought to be, much ahead, was we were sterilizing biopsy needles. I mean, it's ridiculous to think that these things still go on, and because the sort of the supply chain, is different, or the patient won't have money, or, there are many reasons, and I'm going to try not to sound judgmental, but for me it was a reality, it was a shocking thing again, because I thought that this is something we've tackled. I had the same experience in Malawi, and I was like, okay, we are beyond this, And so if there's some amazing things that AI has done, and I would say some of the things you can do is this element of a different type of transfer learning. So a few weeks ago, listening to a podcast, and Netflix is, sort of pursuing emerging markets as the next big customer. Now the challenge for that is data. Data is expensive. I mean, internet is expensive in Nairobi. Even I feel a pinch when I'm back home, and so they've managed that with 4 GB of internet, you can stream almost 30 or 40 movies. I mean, that's amazing, because I started to think, oh, okay, so you can use AI to encode and decode radiology images so that 4 GB can be used to enhance teleradiology. What does that mean when we decode and encode those images? Do they change their diagnostic value? all these are interesting questions. They don't necessarily mean that I'm investing a lot of money there. But as we see a big push of the big companies releasing all their source code, it's going to be interesting to start answering some of those questions as researchers so that when we are ready, we'll have some of the answers. But I think, and I don't think that this will happen, because if you look at one of the things also around internet, and this is not medicine, was when I was home, I realized that if you kept buying more mobile bundles, you got different pricing. And that's sort of like the market forces. But one of the things that was pretty challenging was that Safaricom, which is the big mobile provider in Kenya, would automatically send you messages. So you can imagine if my grandmother got these messages, she wasn't literate enough to unsubscribe because it's this USSD system. And every message you received deducted money from your cell. Okay? So it actually ended up being unintentional, causing harm more than benefit. But all these things, they are known, and the global health circles talk about them, but we're not talking about them when we start to think about AI. And it's easier to do AI in developing countries in terms of, just regulation. I mean, that's just the truth, And so I think we'll have to empower partners. We'll have to empower, I think I had a comment earlier, we'll have to empower when you work with local partners, what that means, and giving them voice, so that they can always say when things are not appropriate or are not timed right. I know a friend of mine who had this situation where they were starting a breast cancer registry, a voluntary breast cancer registry in Eldoret, and the IRB had approved both projects. The American IRB had the equivalent American institution. The IRB said, obviously, this is good. But the local one was going to approve it, and he asked, so what will I do with these women who come back a few years later and they have breast cancer? And they said, oh, but I had this biopsy. And it's a cultural thing. In the US, when you ask women to donate their breast tissue, people come in crowds. But when you go back to Kenya, that's not something that we're used to. And the people who may come may be having a lump or something else. And it's just a different thing when you don't have sort of care to establish care plans. I'm not saying that we should defer the excitement of technology, but I think it would be naive to jump and let's say, and I think we will see governments do this, where they're like, oh, let's focus on AI for a task, instead of still going back to the basics again, properly training physicians and meeting the health needs that truly save lives.
Thank you, Judy. It's a great question that we can take into the rest of the afternoon, right? Where is AI actually, is it the right solution for the problem that we're trying to solve? And that is a perfect segue. We are out of time. I do want to give you sort of a very brief question. When we talked earlier, I learned that you consider yourself an optimist and you consider yourself a realist. So just in one sentence, because we all like to stretch and challenge ourselves here, since you're the optimist, right, what gives you pause? And since you're the realist, what gives you hope?
As usual, I always like Lily to speak us.
Sure. I'm actually kind of a pessimist, if you ask my team. But so I think actually one of the things that do give me pause, that was riffing off of what was just I'm talking about, is we tend to use AI as the sprinkling to get funding or to whatever, right? So it's like a grab bag of words, and then you put AI on there, and it's like, whoop, let's get funding. Oh, and then let's do it in this health setting. There hasn't been sometimes not a lot of thought of saying, well, is AI useful here, right? And if there's no problem, then AI doesn't need to be there, right? So I think that we actually need to be a little bit more cognizant of the places. It's like saying mobile technology. It's like saying any kind of AI is a tool. AI is almost like a language, right? So is Java going to Java and Python going to be useful here? I don't know. It depends on what you're trying to do, right? Like it isn't always there. So I think we need to be a little thoughtful about pouring a lot of resources in places where AI is very flashy, but may not actually be helping.
Well, my hope actually is every morning at 5, I go to the hospital and I have to fax this requisition for doxorubicin for my patient. And I have to call the pharmacy and I have to call them again. So we're still very far, but I guess there's room for improvement, you know, even here before we go to Africa, because, you know, I still hit the EMR, but I think technology is amazing, and you know, for a long time my caption was "Write code, save lives," and I think even just the opportunity to be in a hospital and to look at their problems, I mean, it's just fantastic, you know, and it's awesome. Like you know, I'm envying Lily right now as she's gonna be discovering all these problems because they're amazing to solve.
Let's give a round of applause. Thank you, Lily. Thank you, Judy.